Right, good evening. Sri Lanka College of Obstetricians and Gynecologists in year 2023. Our mission is to advance women health with good governance. So as a part of this good governance, education of the relevant staff, consultants and the junior staff is a priority. So it's in our mandate. So to fulfill this requirement, my very efficient chairman, academic activities and research, Dr. Shamun Malin, has organized a series of very good educational lectures. So we are having the second lecture today on the important topics, important relevant topics in obstetrics and gynecology. Last time we were talking about laparoscopy, hysteroscopy, endometriosis, and the management dilemmas. Today, the topic is the polycystic ovaries and from adolescent to adults. If you really know about the polycystic ovaries, it starts as early as in the menarche. And some people, primary amenorrhea may result from infantile polycystic ovaries. So to discuss this matter in further, and we teach medical students, and we have a market audience joining virtually. To discuss this matter, we have Dr. Namoda Atapattu, who is a consultant pediatric endocrinologist. You know, after 13, they are covering up the 13, and that's the menarche. So this is a good watershed line now than what we are discussing today. And we have some of our infertility trainees. So probably we'll have a very intellectual kind of a discussion, interactive intellectual discussion. And after Navoda, who's going to present first? Gihan or Namoda? Gihan. Okay, Gihan will start the session with polycystic ovaries, followed by Namoda, who's going to discuss about the adolescent aspect. So I thank you very much to the two speakers and Shamun and the sponsors who are hosting this event today. And without taking a time, let's get on with the schedule. Thank you.
Good evening, everyone. So I would like to take the opportunity to introduce our first speaker for today, who, as Professor Dodampahala mentioned, is Dr. Champika Gihan. He will be sharing his expertise with us about polycystic ovarian syndrome in adults. A little bit about Dr. Gihan. He's a consultant obstetrician and gynecologist at the Professorial Unit Teaching Hospital, Peradeniya. He has obtained his MBBS from the same university and his MD in obstetrics and gynecology from the University of Colombo. He's done his specialty training at Whittington Hospital, NHS Trust, London, and obtained his MRCOG from the UK and a CES diploma in advanced gynecological laparoscopy from the University of Clermont-Ferrand, France. Dr. Gihan has won President's Award for his scientific publications in 2009, second place for Best Oral Presentation at the annual academic sessions of the Sri Lankan College of Obstetricians and Gynecologists in 2016. He also won the Sir Professor Sabaratnam Arul Kumaran Young Gynecologist Award in 2017. And once again, another Young Gynecologist Award from Asia-Oceania Federation of Obstetrics and Gynecologists in 2019. Over to you, Gihan.
was new, right? You see, you can move by arrow clicks. You can go to the next slide by arrow clicks.
Good evening to you all. Thank you, sir and madam, for kind introduction. Okay, we'll get into the topic. I'll be giving a start to PCOS, even though some may think we'll start because timeline will start with adolescents, then go to adults. But I will give a brief introduction and we'll then discussing about the PCOS in adults. And I have named the topic as the adult triad of PCOS, and I'm coming to that what I meant by triad. Then Dr. Nawoda will be discussing the specific entities relevant to, especially in the second decade of life, adolescents. I have nothing to disclose, no conflicts of interest. Sorry. Right. So I will be discussing about adult triad of PCOS. And I will come to the thing that I mentioned as triad in my lecture. So I'll be discussing about the gravity of the problem, the particular syndrome with the spectrum, and several phenotypes of PCOS. And then I'm coming to the previously mentioned triad, then diagnostic criteria, which is sort of bread and butter and that you all are aware. Then the triad, there are 3 dysfunctions unique to PCOS. Then little bit on management with specific highlight to the management of fertility and newer agents available in the treatment line of PCOS. This is the commonest endocrine disturbance in women. The prevalence is around 10%. It varies from 8 to 13. The commonest endocrine disturbance in women, I repeat. Another hidden morbidity, 70% of affected females remain undiagnosed, sort of hidden morbidity. And it is one of the main causes for female infertility in the world. And because of the nature of syndrome and other associated comorbidities, the higher chance of comorbidities has led to economic burden in the world. So that is the importance of discussing about PCOS. You know what is meant by syndrome? It's a heterogeneous collection of symptoms and signs gathered to form a spectrum of a disorder. So a spectrum varying from mild to severe form. And if you take an individual, that particular individual may lie in any point of the spectrum. And another important thing in PCOS, that particular severity of the disease in an individual varies. Where the particular individual lies in the spectrum is not solid, it's not permanent. Depending on the age of the individual, where she lies in the spectrum varies. Another important thing. It's a spectrum with varied clinical manifestations, multiple symptoms, and a lot of changes in serum endocrinology and possible late sequelae. What are the symptoms? The spectrum of symptoms, the menstrual disturbance, obesity, the features of hyperandrogenism such as acne, hirsutism, alopecia, infertility, and another thing is significant proportion of females may be asymptomatic. But the disease pathogenesis is continuing. The spectrum of endocrinology, elevated androgens, increased levels of LH, increased fasting insulin, increased prolactin, unopposed estrogen because of annulation, and because of high insulin, reduce sex hormone binding globulins. I'm coming to that in each and every in my future slides. The spectrum of late complications or comorbidities or sequelae: diabetes mellitus, dyslipidemia, hypertension, cardiovascular diseases, malignancies such as endometrial and breast cancers, and another hidden thing that we don't address usually in this part of the world, the psychological morbidity associated with PCOS. The phenotypes. Expression of PCOS begin in utero life. And as I mentioned earlier, symptoms and signs changes across the lifespan of the individual. In the prepubertal and adolescent, not always, but most of the time, generally hyperandrogenism predominates. In the reproductive life, it is all about reproductive dysfunction plus or minus hyperandrogenism. In the postmenopausal life, it is all about metabolic disorders or metabolic dysfunction. So that is the gravity or the burden of the disease from in utero till death. PCOS is affecting a female's life. The pathophysiology, just going through for the completeness sake, is multifactorial. Genetic, epigenetic, and environmental factors placed together. A female may be born with particular genetic and epigenetic component, but she may not express till particular age, the particular syndrome. She may not express. The bad habits like diet, fast foods, or lack of exercise, which leads to weight gain, make the disease expression. So the females are born with the particular genes, but it may not be expressed. Bad habits, which leads to weight gain, make the expression of the full syndrome or the spectrum. Several international bodies who are investigating or who are doing research and making guidelines for PCOS. So I'm just going through again for the completeness sake, the diagnostic criteria which you people are aware. There are 3 criteria. Out of 3, there should be 2, with the exclusion of entities like late onset congenital adrenal hyperplasia, androgen secreting tumors, which may cause virilization, not hyperandrogenism, but virilization, Cushing's, thyroid dysfunction, and hyperprolactinemia. So those are sort of common symptoms and signs common to PCOS and these entities. So these things should be excluded. The criteria number 1 is menstrual irregularity or ovarian dysfunction, which is the central pathology in PCOS. So irregular cycles that continue for more than 2 years post-menarche. That is there in the definition. So we are a bit reluctant to come to a conclusion in immediate after menarche, especially within first 2 years post-menarche. So that indicates oligomenorrhea or amenorrhea indicates oligo-ovulation or anovulation. Criteria number 2, clinical or biochemical hyperandrogenism. It is the symptoms, so signs will be hirsutism, acne, and alopecia or male type hair loss. Virilization is rare. If it is virilization, we have to suspect other pathologies like CAH or androgen secreting tumor. We use, in biochemistry, we use free testosterone or free androgen index to assess the biochemical hyperandrogenism. Criteria number 3, which is ultrasonic, endovaginal ultrasound scan, 8 megahertz frequency, the PC, polycystic ovarian morphology on either ovary. Follicle number more than 20 and ovarian volume more than 10 cc or 10 milliliters. That is because of cortical thickening and stromal hyperplasia, and there are multiple immature arrested follicles in the periphery. So this is the triad that I mentioned. It is, now we discuss PCOS in terms of disturbances in reproductive functions, endocrine functions, and metabolic functions. But now they will agree, we have the authority as gynecologists to discuss about PCOS because ovarian dysfunction is central. But not pediatric endocrinologists, but physicians or adult endocrinologists may disagree, but ovarian dysfunction is whatever said and done, it is the central. So it's our organ, ovaries. So again, MDT I'm discussing, it's again triad, it's an MDT management involving not only the gynecologists, but endocrinologists and physicians. Right. Because of the easiness, I will discuss endocrine dysfunction in PCOS, then it is easy to build up the lecture. It is all about insulin resistance and compensatory hyperinsulinemia with hyperandrogenism. That is the insight into the pathogenesis of PCOS. Hyperandrogenism, insulin resistance, hyperinsulinemia, high LH, low sex hormone binding globulins, and unopposed estrogen with low progesterone level, and high prolactin. Those are the summary of endocrine changes. So I'm coming to each and every. Why they are having hyperandrogenism, high LH level? So those are interconnected, making the disease sort of complicated. High LH increases the androgen synthesis by theca cells. High insulin potentiates that action, as well as insulin reduces sex hormone binding globulin synthesis from the liver. Then fasting androgen, free androgen index is increased. This increased intra-ovarian androgen level is responsible for follicular arrest. That is the one which causing anovulation. You know these figures? The normal testosterone, we take it as 0.5 to 3.5 millimoles per liter. If it is more than 5, always exclude malignancy or late onset CAH or Cushing's. Between 3.5 to 5 is the range that we generally see in PCOS, which causes hyperandrogenism but not virilization. Usually PCOS does not cause virilization. Second endocrine disturbance is insulin resistance and hyperinsulinemia. That is mainly because of reduced sensitivity because of post-binding abnormality in insulin receptor mediated signal transduction, which is, it's an inherent defect or intrinsic defect, which is independent of obesity. Obesity gives an additive effect. So because of post-receptor signal transduction defect plus obesity, both causes insulin resistance, which leads to compensatory hyperinsulinemia. And intermenstrual interval correlates with degree of insulin resistance. So you can gather information from the history, then you know this female is having a high insulin resistance if the intermenstrual interval is prolonged. By the hyperinsulinemia causes trophic changes to the skin, which causes acanthosis nigricans. Increased LH, sort of nasty in PCOS. High LH secretors, or we call it as slim PCOS. This is the difficult group in terms of managing fertility or subfertility in those females. So slim PCOS usually resistant to treatment, and outcome is, compared to obese PCOS, outcome may be poorer. And another correlation, ovarian volume is correlated with serum LH level. For part 2, those are EMQs points. Intermenstrual interval correlates with insulin resistance. Ovarian volume correlates with LH. Reduce sex hormone binding globulin level. That is because of hyperinsulinemia inhibits that particular protein synthesis from the liver, which increases free androgen index. Hyperestrogenism, that is unopposed estrogen because of anovulation. There is no corpus luteal formation. She is lacking progesterone. Reduced progesterone, absence of corpus luteum. And these are the figures that we are taking sort of generally. If the serum progesterone level is more than 30 nanomoles per liter, it is suggestive of ovulation. If it is less than 15, suggestive of anovulation. In between may be correct timing, incorrect timing. And there's you must have seen the PCOS patients, they are having sort of mildly elevated prolactin levels, but not to the levels that you get in microadenoma or macroadenoma of the pituitary. This also, high prolactin also contributes to anovulation. Second dysfunction, reproductive dysfunction in the triad. It is all about menstrual irregularity or menstrual dysfunction and subfertility. Menstrual irregularity because of anovulation or oligoovulation. And as I explained, intraovarian excess androgens causes arrest of follicular development. Longer the intermenstrual period, poorer the outcome. Subfertility, obviously because of anovulation. Increased androgens upregulates the level of AMH, and this AMH inhibits follicular genesis by inhibiting the FSH effect. So that's again I told there are a lot of interconnected mechanisms, endocrinological changes happening with PCOS, which has a sort of additive effect or may act as a boomerang and causing, at the end of the day, causing a poor outcome. Another association, AMH can be used as a biomarker to assess the risk and to monitor the prognosis. Sort of upcoming thing, infertility. And another thing associated with PCOS is recurrent implantation failure and miscarriage. That is because of PCOS reduces endometrial receptivity, changes the endometrial microbiota, increase subendothelial waves or endothelial or uterine contractions, which hinders or prevents implantation. So those are very early things happening. Even the female does not know that her egg was fertilized, and now it's implantation failure because there is no sort of period of amenorrhea. Very early implantation failure. She's thinking she's bleeding after less number of days, and she's thinking it's a normal menstruation. Third dysfunction in the triad is metabolic dysfunction. So again, the physician's part. It is all about obesity, type 2 diabetes mellitus, dyslipidemia, hypertension, and cardiovascular diseases, which increases the economic burden to the patient, family, and to the maybe country or to the whole world. Obesity, you know, what you get in PCOS is visceral adiposity or central adiposity, or we call it android adiposity. The apple shape. There are good studies done by Chandrika Vijayaratna madam in Sri Lanka as well. Why this is the visceral fat is metabolically active? There is a bad part which leads to insulin resistance, type 2 diabetes mellitus, dyslipidemia, and hypertension. This visceral adiposity is correlated with insulin resistance and metabolic dysfunction. Now, everyone is talking about the adipose tissue as an endocrine organ, the largest endocrine in the body, and it is metabolically active, and there is low-grade inflammation. It releases pro-inflammatory cytokines, TNF, interleukins, and relatively new concepts are dysbiosis in gut microbiome and disturbance in gut hormones. All are happening in PCOS, or all are happening with obesity or central adiposity, which is there with PCOS. I'm just summarizing few studies of meta-analysis, which has taken from 9 prospective studies and 14 retrospective studies. Average follow-up time is 5 to 31 years, which is sort of significant duration. These are the risk ratios. For hypertension, 1.7 times, type 2 diabetes 3, total cholesterol 7.1, LDL 3.3, HDL, the good cholesterol minus reduction in minus 2.4 times, triglycerides is 18. See the gravity of the problem. The impaired glucose tolerance and type 2 diabetes mellitus in PCOS, insulin resistance combined with central obesity, it are the culprits. 20% of slim women and 40% of obese women with PCOS demonstrate impaired glucose tolerance. 40% is a big figure. The markers for cardiovascular diseases in PCOS, triglycerides, and LDL are higher, and inflammatory markers, CRP, interleukin 6, TNF alpha, and ACE, advanced glycation end products, and ADMA, asymmetric dimethyl arginine, sort of novel markers, which medical people or physicians are taking as markers for cardiovascular diseases. Then there is endothelial dysfunction or vascular disease in PCOS, increased arterial stiffness, increased intima media thickness, and you get high levels of homocysteine in PCOS, which leads to atherosclerosis. Another meta-analysis for vascular events. Risk ratio for coronary events is 1.8 almost. Cerebrovascular events is 1.4. PCOS and malignancies. It is all about endometrial malignancy and breast malignancy. Endometrial hyplasia and malignancy is seen in PCOS, that is mainly because of unopposed estrogen activity in the body, obesity, nulliparity, and subfertility. Because of that, if the female is severely oligomenoric, we have to induce menstruation, artificial withdrawal bleeding, right? If that particular female fail to respond to that artificial withdrawal bleeding, that endometrium should be sampled to exclude hyperplasia or even malignancy, which can be coexisting. Breast cancer, again, because of obesity, hyperandrogenism, and subfertility or infertility seen in PCOS, those becomes risk factors for breast cancer. This is the entity that we don't address very much in our setup or in our culture. Impaired health-related quality of life, low self-esteem from obesity and poor body image, psychological stress due to hirsutism, frustration in attempts to lose weight because most of the time they are failing, mood disorders and depression, social stigmata with subfertility, and obstructive sleep apnea. I'm not going to elaborate those things because I am not a psychiatrist. In Peradini, we call psychiatrist. Psychiatrist. Okay, management. Obviously, is MDT. These are the modalities that I could divide the management modalities: lifestyle changes or lifestyle advice, addressing the obesity, addressing the hyperandrogenism. What can we do? What can we do for menstrual irregularity, which is a concern of the female? How can we treat subfertility associated with PCOS? And I'll be touching few newer agents in the market. Non-fertility aspects of PCOS, and I have mentioned as but these aspects indirectly improves the fertility outcome. If we are addressing the obesity, that obviously I would say I should not say indirectly, but directly affects fertility outcome. So lifestyle advice, these things you know. What we advise is healthy eating and regular physical activity. Usually, if we at least 30 minutes brisk exercises per day, but to have a sustainable weight loss, 60 to 90 minutes per day with calorie restriction. What are the problems of obesity? I have summarized here. Obesity causes reduction in fertility in both. Forget the female. Obesity in males, reduction in sperm count, sperm quality, sperm functions. Obesity increases risk of miscarriage. And now we discuss obesity as a teratogenic agent or entity. And somehow or the other, if the female get pregnant, obesity causes complications in pregnancy, gestational hypertension, diabetes, problems during delivery, starting from simple manual handling of the female, our theater table or the labor ward table may not be enough, trauma to the mother, trauma to the neonate. So at the end, it is all about increased maternal and fetal morbidity and mortality from obesity. So what can we do? Lifestyle and medical treatment as well as surgical management. The advantages are it improves the endocrine profile, increases the chances of ovulation, and at the end increases the chances of healthy pregnancy with low maternal and neonatal mortality morbidity. So metformin, even though it's very hugely used, it's a debate, it's a question mark. Now, at present, the uncertain in the place of metformin in the treatment of PCOS is a question mark. Anti-obesity drugs, you know, Orlistat and sibutramine, both improves insulin sensitivity. It is licensed for females who are BMI is more than 30. Bariatric surgery, if the BMI is 35, or if there are comorbidities, it is addressed even for females who BMI is less than 35. How to address hyperandrogenism and hirsutism? The drugs which we are using and the anti-androgens are cyproterone, acetate, spironolactone, drospirenone. We have to combine with estrogen because estrogen reduces gonadotrophins and androgen synthesis and it increases the synthesis of sex hormone binding globulin from the liver. So it is COCP, combined oral contraceptive pills. Eflornithine, which inhibits ornithine decarboxylase in hair follicles, and the other things which we are not dealing with, or Chandani Bandara, or I don't know who are big figures in Colombo, they are dealing. It's not VOGs. Menstrual irregularity, again, what we are using is COCP. But here, if we can use a progesterone with predominant anti-androgen properties, will be the best. Examples are cyproterone and rosperinones, though those progesterones are having mainly anti-androgenic properties. This is what is I highlighted earlier as well. If the endometrium is thicker more than 10 millimeters, in an ovulatory woman, always try to induce menstruation. If she fails to menstruate with that withdrawal bleeding, that endometrium should be sampled. Endometrial hyplasia is very common. We don't think, we don't understand the gravity of the problem. Then now I am coming to the management of fertility or subfertility associated with PCOS. First of all, optimize health before you start in the treatment. Otherwise, it's unfair by the patient. You may do more harm, and it increases the response to treatment, chances of pregnancy, as well as reduce the complications in pregnancy if she gets pregnant. Our objective is to achieve a singleton pregnancy with reducing the risk of OHSS and multiple pregnancy. That is the objective. That should be the objective in fertility treatment in PCOS. Another problem that we encounter in PCOS, in treating PCOS female, is very difficult to predict the response to standard ovulation induction treatment protocols, unlike a non-PCOS patient. So it's a sort of trial and error, and the particular cycle that we are treating become a sort of investigation for the subsequent cycles. We know how was the response, and we can't predict in PCOS. So it becomes a sort of assessment for subsequent cycles in future. That's the beauty. So these are the things, clomiphene citrate, which was the sort of gold standard now. So the first line, but now aromatase inhibitors has become the first line for PCOS, ovulation induction, and gonadotrophins and surgical, laparoscopic ovarian drilling. With clomiphene, the ovulation is around, the chances of ovulation is around 80%, but the pregnancy rate is around 35 to 40%. The reasons may be clomiphene resistant increases both because it inhibits the feedback mechanism. Because of that, it increases LH, FSH both. And the female who are already having high basal LH level, they are less likely to respond. And it is a SERM, selective estrogen receptor modulator. It has anti-estrogenic properties at the anterior pituitary level. That's how it blocks the negative feedback mechanism. But it has estrogenic properties at the higher centers, but it has anti-estrogenic effects in the cervix, endometrium, and cervical mucus. So that is, which is not good at the time of ovulation. There should be good estrogenic effects on the endometrium and cervical mucus for implantation, for the sperms to travel. But this is a SERM, it's a modulator, so that anti-estrogenic properties may hinder the ultimate outcome or block the ultimate outcome. That is the explanation for higher ovulation rate with lower pregnancy rates. Letrozole, now it has become the first line because it doesn't have adverse effects on the endometrium or cervical mucus because its mechanism of action is different. It's an aromatase inhibitor. Nothing to do with blocking the feedback inhibition. So negative feedback mechanism is intact. Then there's a negative feedback mechanism which with high estrogen blocks the FSH, which favors monofollicular development. So less chances of multiple pregnancies with letrozole. And another beauty is shorter half-life when compared to clomiphene citrate. Because of those three reasons, it is a first line for ovulation induction, oral ovulation induction in PCOS. So pregnancy rate is 15 to 33% per patient and 16% per cycle. If the patient is clomiphene citrate resistant, higher ovulation rate and higher pregnancy rate. Metformin, as I told, it's a sort of question mark, the place of metformin in PCOS. However, it lowers the fasting insulin concentration directly on theca cells to reduce androgen production. And female may menstruate and oligomenorrhea may improve. But significant numbers of patients remain anovulatory. And even though a lot of physicians say a lot of mechanism of action, there will not be significant change in BMI or waist-hip ratio. And again, we are using very subtherapeutic dose. If we need to use metformin, the dose is 1,500 to 2,500 per day in 2 to 3 divided doses. So 500 per day Nocte or 850 SR or extended release at Nocte is not going to work. Because of the latest evidence, ESHRI and ASRM has concluded insulin sensitizer should not be the first line. And it is second line agent with clomiphene citrate or letrozole. There's a place. But again, some have challenged that statement as well. Gonadotrophins, when compared to conventional protocol, the best would be the low dose step up protocol, maybe starting from 75, give for 14 days, see the response, do the follicular tracking. If need, increase the dose by 25 or 37.5. So that is low dose step up protocol. With that, ovulatory rate is 70%, which is a very good figure. And pregnancy rate is 38% of patients and 20% per cycle. Why are we using the low dose step up? To reduce the risk of OHSS and multiple pregnancies. Then surgical management, laparoscopic ovarian drilling. Why? It is free of the risk of OHSS, multiple pregnancy, and that particular female does not require ultrasonic follicular tracking. So if the female's compliance is low, this would be the best. And we do only once for life. Action may last for 12 months, 18 months, different studies, different duration. And only minimal ovarian damage is required to achieve the effect. There will be ovarian damage, but it is minimal that you need to stimulate ovaries surgically. So what are the indications? We don't do drilling as a first line. So indication, fail to ovulate with oral agents. And the female had history of OHSS or CVOHS to the other treatment modalities. This has a special place for hypersecretors of LH. So they may be at risk of OHS. So surgical, I would not say again should be the first line. But remember, slim PCOS, laparoscopic ovarian drilling has a better role to play. And female who are difficult to follow up, poorly compliant. And if we think now we need to assess her tubes as well, or we need to assess her pelvis, minimal to mild endometriosis or pelvic infection, then do both together. Diagnostic laparoscopy plus laparoscopic ovarian drilling. There are some concerns, risk of surgery as well as anesthesia, adhesion formation after diathermization, and mild reduction in ovarian reserve because of thermal damage. Last resort is IVF. We use IVF in PCOS patient if there is another reason for subfertility other than PCOS, or now we have achieved ovulation, but she has failed to conceive. So again, PCOS, but we make her ovulatory, then it becomes unexplained. In those two scenarios, yes, there's a place for IVF. Okay, I think I did the main part of the lecture. Last few slides. Newer agents, inositol. Lot of products are there in the market. Variable efficacy in improving insulin signaling and metabolic outcome. We are using, physicians are using, endocrinologists are using. GLP, glucagon-like peptide receptor agonists. Again, glucose lowering and reduce cardiovascular events in type 2 diabetes mellitus. In PCOS, weight loss and improving metabolic outcomes. And another newer agent, what we have in this part of the world, Ceylon cinnamon. Sort of marketing, one of my study. These are the properties. And Prof. Rana Singh from Colombo, he has done a lot in general medicine aspect. These are the properties of Ceylon cinnamon. Anti-inflammatory, antioxidant, anti-diabetic, antimicrobial, cardiovascular protection. What is the place of PCOS? In PCOS, improves insulin sensitivity in PCOS, lipid profile, chances of ovulation, and its sorry, overall benefit. Okay, thank you for listening. I'm happy to answer any question. Yes, please. Okay. Yeah. AMH is the best marker for ovarian reserve, because it doesn't have intercycle or intracycle variation, right? But we have to be a bit alert in using AMH to assess the ovarian reserve in PCOS, because PCOS per se increases the AMH level. Sorry, I can't. Make it. Yeah. Why are they having high AMH level? Because of high androgen levels in the circulation as well as intra-ovarian. And this the last sentence which I have mentioned is sort of, we don't at the moment, we don't use very much in clinical practice, but research evidence says we can use this as a tool to assess the risk or the prognosis or response to treatment in PCOS. Higher the AMH, poorer the outcome. in PCOS. That doesn't mean the take-home message is same. A female or couple comes in 40s. If their MH is relatively good, we are happy. Right? We know some ovarian reserve is there. But we can't go by that rule in PCOS women because hyperandrogenism seen in PCOS upregulates AMH. And AMH directly inhibits follicular maturation by inhibiting the FSH. So it's badly affecting. So you have to be very, that's what I want to highlight, sir. We have to be very careful in interpreting AMH in PCOS females. Any other question? Yes, it appeared, now it's sort of disappearing like.
These androgen level being very high in polycystic women. Now, androgen level is correlated to libido in women. So what does it imply? Does it mean that women with polycystic ovarian disease have higher sex drive?
Good question, sir. I can remember you asked the same question when I was a registrar. Again, I didn't have an answer. Again, today.
You
also-
should have one by now.
Could you please explain, sir?
You should have one by now.
Theoretically, yes, sir.
But in practice, I think it's the other way around.
But it's
because I think they
multifactorial,
have
you know,
started what
that
we-
particular female is obese, sweet, the attraction will be poor.
Yeah. Self-image, I think it's a case of body image and self-image. Probably it's poor. But I think it's worth looking into because, I mean, if it is supposed to be the driving force. Let me ask you something different. I mean, you gave a brilliant lecture covering every aspect except perhaps you didn't touch on the bladder.
Okay, sir. Thank you for the comment and the questions.
Yeah. Would you mention anything about the bladder functions in PCO?
Sorry, sir, I
Fowler's
didn't get it.
syndrome, for the sake of the postgrads, the bladder functions in PCO, like Fowler syndrome and things like that.
I have no idea, sir.
Right, okay. It's a bladder, you know, you get chronic retention in young girls and it's virtually incurable. And the association between PCO and Fowler syndrome is 50% in Fowler syndrome. It's a very serious condition, debilitating and incurable.
Mhm.
So, I mean, just for completeness sake, I just thought of mentioning that because there are postgrads listening on
Yeah, thank you, sir.
in young girls, and it's quite debilitating and you can't cure it. And a very high association, 50%. Also, for the sake of the postgrads, could you clarify between this multicystic and polycystic ovaries? Now, we sometimes describe the ovaries as multicystic and sometimes as polycystic. How would you distinguish between the two?
The multicystic, we usually comment if we are unable to perform a transvaginal scan, especially in the second decade of life, and it is not fulfilling the what do you call the criteria to diagnose PCOS, because maybe female is not sexually active. In that case, we can't do transvaginal scan, so we have to rely on the transabdominal scan, and she is sort of young for the reproductive life or very early post-menarcheal life. Then again, that just because we can't diagnose, we can't conclude, we may label it as a multicystic. Keep in mind that she's at risk of developing the full spectrum or full syndrome in future.
Right. Also, as to why the criteria for PCOS has been changed with time. They've changed from 10 follicles to 15 to 20, again to 15. Whether we are overdiagnosing this, what is the logistics behind this shifting? At one time, the request was for 20, then it was 10. Another time it was 10. Now it's 15. So are we overdiagnosing, and can we take population statistics? Even the hormone levels for the normal population are so polluted by this large cohort of women with polycystic ovaries. So we can't even interpret normal population data, because by some studies, the population incidence is over 25% of women. If you take the asymptomatic group of women and you do it on a research basis, and then suddenly find that a huge number of women in what we call normal people are having PCO. So then what we use as normal values for people, for women, are hugely polluted.
Yes, sir.
The normal statistics.
Polycystic ovarian morphology may exist without manifestation of the full
Yes.
spectrum.
Spectrum. Yes. Thank you, Gehan. It was a brilliant rendering, and you have done a lot of homework. And this is a very easy passive way of updating myself without having to read too much. Thank you for your hard work.
Thank you, sir, for the comments.
Okay.